So in this video, we're going to cover the different types of dyskinesias, all right? So here, we're going to say that a dyskinesia, what is a dyskinesia? Generally, it's an abnormal and involuntary movement, right? And so, let's go over, the first one that we want to go over is chorea, or chorea, however you'd like to pronounce it, but chorea. And so chorea is a jerky, dance-like movement. So a keyword here is that it's dance-like. It's a dance-like movement. And you'll see it, it can be either localized to specific parts of the body or generalized across the body. But one thing that you'll see is that it has a preference for the distal appendages. So it has a distal preference. So that's like, the arms and elbows and stuff like that. And so in these types of things, we have to localize the lesion. So when you're localizing the lesion with chorea, you really are thinking of anything that causes a lesion to the striatum, which is the caudate plus putamen of the basal ganglia. So any striatal lesions are going to result in this disinhibited kind of a dance-like movements called chorea. And what are the diseases that we see this most classically in? We see it in Huntington's, which you can kind of think of as the opposite of Parkinson's. We have excessive movement, so Huntington's disease. We also see it after a rheumatic fever in children. This one's called Sydenham's chorea. A rheumatic fever infection in children can cause this type of chorea. And then we also see it in hyperthyroidism, also known as Graves' disease. So I always like to include a non-primary neurological disease that you can kind of see some of these neurological symptoms or deficits. So this is kind of that overview of chorea. Now, you'll also hear word of athetosis. And depending on when you're watching this video, this may or may not be conflated with the term dystonia, but I'm going to treat athetosis and dystonia as separate dyskinesias. So for athetosis, it's a slow, writhing, keyword writhing movement, okay? And it's like snake-like, and you'll see it particularly in the hands. So you'll see it particularly in the hands, that writhing of the hands/fingers is athetosis. It can be generalized to both of your arms/hands, and it shows a kind of diffuse upper limb preference. So diffuse upper limb preference. It doesn't discriminate or show preference for one arm/hand over another. And it is also, similar to chorea, athetosis is also associated with lesions to the striatum. And so, not surprisingly, the classic disease that you see athetosis is in Huntington's. Very classically associated with Huntington's. So the next one that we're going to go over is hemibilismus. Hemibilismus. And so for hemibilismus, what you see is this violent flailing movement. And as it's in the name, hemi means one side. So you'll see it on one side of the body, and it has a preference for the proximal muscles of the shoulders and hips. So it has a preference for the proximal. And so you'll see that in the shoulders and hips. That's a very key way to distinguish it from other types of dyskinesias, is that proximal preference. And so then you'll see, this violent flailing movement is often seen as like, kind of a ballistic-like, a throwing of one arm. But remember, it's hemibilismus, so you'll really only see it on one side. And it is associated with a lesion specifically to the subthalamic nucleus. And importantly, it will manifest contralaterally to that lesion. So, for instance, if you have a lesion on your left subthalamic nucleus, your right arm will be violently flailing, and vice versa. So that's very specific, very, very specific for hemibilismus, is this lesion to the subthalamic nucleus of the basal ganglia. And so not surprisingly, what leads to this lesion? Something very specific, like a Lacunar stroke, right? And then, interestingly enough, through a different mechanism, you'll see that non-ketotic hyperglycemia will also affect the subthalamic nucleus and can cause hemibilismus that can be reversed by treating the hyperglycemia. So that's kind of an interesting non-primary neurologic etiology for hemibilismus. And then the next one that we want to cover is dystonia. So dystonia is a sustained contraction. So that's the key word there, sustained. It's a sustained contraction. You can contrast that to the following dyskinesia that we're going to discuss, which is more kind of shock or lightning-like. This dystonia is sustained muscle contraction. And notice that we've now moved away from complex movements, right? So notice that hemibilismus is a complex movement. Your entire arm will flail out, right? And that involves the activation and contraction of multiple different muscle groups. You'll also see that athetosis is that writhing movement. It's a complex movement involving contraction and rotation around joints. And then chorea is a dance-like movement. It's also a very complex movement. But dystonia, we're now starting to move away from those complex movements to kind of simpler muscle contractions. They still result in movement, but it's not as complex, so it's engaging less muscle groups simultaneously. And so for dystonia, you'll have the sustained contraction, and it can be generalized. It shows a preference to the upper limb, specifically the dominant upper limb. So we have that dominant upper limb preference. And so this is a way to distinguish it from athetosis. Remember that athetosis is diffuse upper limb preference, right? So it'll affect kind of both arms and hands at the same time, and not necessarily equally, not necessarily symmetrically, but it won't show a preference, versus dystonia shows a preference for the dominant upper limb, specifically your dominant arm/hand, the one that you write with. A common form of dystonia is that writer's cramp that you might get from writing excessively with a pen or pencil. And so clearly that shows a dominant upper limb preference for dystonia. The lesion or lesions that result in dystonia are not as specific as that of the previous ones that showed. So you can see with chorea, it cares about it can be localized specifically to the striatum. Same with athetosis and hemiballismus. You can do it with the subthalamic nucleus, right? With dystonia, it can involve multiple different areas across the basal ganglia that could be lesions. So we'll just say that the lesion is classically in the basal ganglia. And so what diseases or states do we see dystonia in? Classically, we'll see it in Parkinson's, and that makes sense because Parkinson's is a disease of hypokinesia, so not enough movement, and dystonia is this sustained contraction, almost like a muscle cramp, and so you won't actually have a lot of movement. It's almost a freezing up of that muscle. So you'll see it with Parkinson's, that limb rigidity, and then you'll also see it with some more so extracerebral diseases such as Wilson's disease, which is an accumulation of copper due to a damaged liver, so liver damage. And so the liver, copper accumulates in extrahepatic sites such as the brain and can cause neurological deficits. So that's Wilson's disease. And then you can also see it in neuroleptic malignant syndrome. Neuroleptic malignant syndrome, where excessive dopamine blockade through these antipsychotics or neuroleptics can cause the patient to enter a state in which they become very tense and rigid and they're unable to move due to that dopamine blockade. And so that would result in this kind of profuse dystonia. And so then the next one we want to discuss is myoclonus. Myoclonus. And so for myoclonus, so we can contrast it immediately to dystonia. Myoclonus is a brief shock-like, so it's brief, it's not sustained, and it's kind of lightning or shock-like muscle contraction. Once again, it's a simpler, less complex movement, and it can be. So the thing with myoclonus is it has a diverse, wide array of etiologies. So many things can result in myoclonus, ranging from several places across the nervous system. So it can, as a result, the presentation of myoclonus, which limbs and which parts of the body are undergoing these shock-like contractions, can either be localized, or it can go all the way to generalized myoclonus, generalized. And so then. So generalized meaning like multiple sites across the body can be undergoing these contractions. And analogously, or kind of in a parallel way, the localization of a lesion for myoclonus is not very specific. So it can be anywhere from the upper motor neuron damage all the way to the spinal cord. And so remember, when we localize a lesion, we can start at the cortex, so there's cortical damage, and that's where you'll see kind of upper motor neuron damage, and it can go down to the through the internal capsule and then into the basal ganglia. So then we can kind of stop at the basal ganglia. We can then continue to go through the basal ganglia into the thalamus and cerebellum, and then down through the brainstem and into the spinal cord. So any of those areas, lesions in any of those areas can result in myoclonus. Okay, and so then what are some disease states classically associated with myoclonus? We'll see this in renal/liver failure. Where remember that when we have renal, when the kidneys and the liver aren't doing what they're supposed to do, which is filter out blood, for the kidneys, they filter in and out electrolytes and certain components of the serum, and the liver detoxifies blood. So when either the kidneys or the livers are not working to their full capacity, we can have accumulation of substances that can have exert toxic effects on the brain. In the liver could be ammonia, for example, and can cause these encephalopathies. So renal/liver failure, you'll see myoclonus. You'll also see it classically in Creutzfeldt-Jakob disease, or this prion or brain protein misfolding disease, which can cause a spongiform brain tissue. And then you'll also see it in this Parkinson plus disorder called corticobasal syndrome. Corticobasal syndrome. And this is kind of a review of these Parkinson plus disorders. But what are the classic findings of corticobasal syndrome? You'll see that asymmetric apraxia, so they won't be able to, they'll lose skilled and purposeful movements on one side of their body, such as screwing in a nail or a light bulb or combing your hair. You'll see myoclonus, of course, and then you'll even see an estrangement or loss of agency over a limb, so that alien limb phenomena with corticobasal syndrome, and it's in the name. It's degeneration of the cortex and the basal ganglia. And then you'll also see it, myoclonus, in serotonin syndrome, where we have excess serotonin, and it results in sort of the opposite. I like to think of it as the opposite of neuroleptic malignant syndrome. Serotonin syndrome we'll have these tonic-clonic jerky movements, and so you'll see kind of myoclonus in that. The next one we want to cover is clonus. Okay, so clonus itself isn't necessarily a dyskinesia. These last two pathologies that I'm going to cover aren't necessarily dyskinesias, but they're related, and you'll see them a lot in your preclinical and clinical encounters. So it's important not to get them confused with the ones that I've already covered. So clonus is a rhythmic, oscillatory, spastic, I like that word, spastic contraction. So we're still talking about muscle contractions or contractions of muscle groups and not complex movements. It's associated with hyperreflexia. Hyperreflexia. And so, as a result, the affected scope of what clonus affects is much more focal or localized, right? Localized/focal. And it's classically a sign of upper motor neuron damage that is what clonus tells you. Clonus cues you into some sort of upper motor neuron damage. So think of the descending, pyramidal motor tracts, and bring you to the upper motor neuron part of those tracts. And so then, where do we see clonus? So for clonus, we'll see it in diseases like ALS, right, amyotrophic lateral sclerosis, which presents famously with upper motor neuron and lower motor neuron damage. So the upper motor neuron part of ALS, we'll see clonus. We'll also see it with multiple sclerosis, so that's autoimmune demyelination of the central nervous system. And then we'll see it with cerebral palsy in children born with cerebral palsy. And interestingly enough, we'll also see it in serotonin syndrome. And this is one of the few cases in which, so serotonin syndrome is one of the few cases in which you'll see both clonus and myoclonus. So despite their names sounding similar, clonus and myoclonus don't typically co-occur, or they're not typically comorbid conditions. And so, but that's the exception to that is serotonin syndrome. You'll see both the shock-like contractions of muscles of myoclonus, and you'll also see that rhythmic oscillatory spastic contraction in clonus. And so then, for the last one that we're going to cover is in a class of its own completely, and it's known as a fasciculation. So fasciculations are irregular and therefore non-rhythmic contractions of individual muscle fibers, maybe a group of muscle fibers at a time. So now we're getting to a much smaller, affected scope. We went from complex movements of chorea to, a smaller scope of the contraction of individual muscle groups of myoclonus and clonus, and then now we're down to contraction of muscle fibers within individual muscles. And so as a result, fasciculations do not produce movement. They don't result in any visible movement. What they do result instead is a visible twitch of muscle that you can see over the skin, but it doesn't result in a movement. So it'll be noticeable to the patient, and if it occurs in clinic, even the doctor may be able to see it over the skin, but it does not result in any sort of movement or kinesis. So as a result, it can't really be classified as a dyskinesia. And then what we see with fasciculations is they're localized, and that makes sense because they have a very small scope to individual muscle fibers, and they are a result of lower motor neuron damage. So that's what really sets them apart. This is something you'll see in lower motor neuron diseases. And so as a result, you can see it in ALS and the lower motor neuron component of ALS. Remember that the upper motor neuron component of ALS involves clonus. The lower motor neuron component of ALS involves fasciculations. And I threw this in there. You can also see it in electrolyte disturbances or imbalances, such as low potassium or hypokalemia. So just because a patient is complaining of fasciculations doesn't mean you have to jump immediately to ALS in your differential. You should definitely have ALS, as part of your differential, but it could be that they could need their electrolytes corrected. They could be low on potassium. And that is our review of all the different types of dyskinesias. Thank you. Before we log off, here is a table I wanted to include that summarizes all of this information for your to help you out with your studying. And thank you very much.